So hi everyone. Thank you so much for joining this session. I am particularly excited about this session. One of my favorite things about starting at Stanford has been including innovation in our resident curriculum. And one thing that I address every year preemptively is the question, is this relevant for me if I'm not going to informatics or operations? And the answer is, of course, yes. Innovation, specifically AI, which is our theme this year, can empower work across all of the EM specialties, as evidenced by this panel. And so I'm very excited to introduce our speakers who we've put together into a talk to demonstrate just that. We have Dr. Christine Ngaruiya, who will be talking to us about using AI in global health. We have Dr. Brian Rice, who will talk to us about using AI in wilderness and rural medicine. And lastly, we'll have Dr. Stephen Gradwohl, who will illustrate its use in pediatric simulation. So covering some of the EM specialties where one does not traditionally go looking for it. And so without further ado, I will start by introducing Dr. Ngaruiya. So Dr. Christine Ngaruiya is an associate professor in the Stanford Department of Emergency Medicine, and she is the Population and Global Health Research Director for the department. She has held several national and international leadership positions, including with the Society of Academic Emergency Medicine, the Consortium of Universities for Global Health as current co-chair of the Research Committee, and the African Federation for Emergency Medicine and Women Lived Health. So it is no surprise that today I'm introducing her from Nairobi, Kenya. Take it away, Dr. Ngaruiya.
I think I'm muted. There we go. One more time. So great to be with you all here today. My name is Dr. Christine Ngaruiya, as you've heard, and I'm really excited to be saying good morning, good afternoon, good evening to some of you in my part of the world, because I understand there's maybe 15 different countries and locations represented. But I'm super grateful, honestly, to the organizers and coordinators for not forgetting about global health and for inviting me to speak. And I look forward to motivating and maybe even inspiring a few of you who are thinking about this from the global health lens. I'm going to start first by telling you a little bit about who I am, right? What's a bit of my story that brought me to work in AI that many of you are probably thinking about, and that's why you've joined this exciting StEMI conference and are already on fire today, right? So I'm an emergency medicine physician, like many of you. I'm also a global public health researcher, and I think a lot in my waking hours about global and various public health issues. My particular area of research is on non-communicable diseases, or what are called non-transmissible diseases, like heart disease and strokes and cancers and diabetes. And I think about this a lot in low and middle income country populations. I also identify, also probably like many of you, because we're EM physicians, as a social entrepreneur and someone who cares a lot about transdisciplinary work. And I think about transdisciplinary work today, especially in global health, to say that if we are not working in a transdisciplinary fashion in terms of limited resources in global health, then we're probably not doing something right. And so I want to encourage all of you today that even as you're going along your work, even as you're dabbling with AI or maybe already working on it, to really be thinking from that transdisciplinary lens, whether you're in global health or not today. I'm also someone who thinks a lot about health equity, right? I care a lot about this, and I think about who is not accessing care today and why, and what are some of the reasons and ways that we can address this. Some of you I know in the room are from various backgrounds, so I wanted to define this a little bit better. And I always really like this figure by Craig Frohl that I think best encapsulates this idea of health equity and equity. And it's really this idea of the liberation and equal access to care for everyone without barriers, without boundaries, and in equal fashion to counterparts. And ensuring that, per the WHO definition of health, we're ensuring a state of complete physical, mental, and social well-being, and not merely this absence of disease or infirmity, but people are actually well, right? And it's also ensuring that we have the highest attainable standard that's being achieved, regardless of background, regardless of race, religion, political belief, economic, or social condition. And so I have an interesting background, also like many of us in emergency medicine, that started actually with sociology, stumbling upon this thing called sociology of health as a confused Kenyan American returning back to the US undergrad. And I learned these terms like health disparities and social determinants of health and health inequity, and realizing that health is actually really inequitable in a lot of parts of the world, including the US. And so that led to a keen interest in my undergrad thesis, looking at inequities in health and systematic differences in women and people of different racial ethnic backgrounds. And we published that work many years ago. Now I'm aging myself. But I've also gone on to think about it in refugee populations, right? And thinking about simple solutions that we can use, low resource, but high impact, like health education, right? And developing a service learning program in the Midwest for refugee populations there. And then somewhere along the way in my master's thesis, like happens with students, I discovered this thing called mHealth, right? It's like mHealth, what is that? And I had this mentor at this kind of cool school in the middle of London, Dr. Carolyn Free. She's amazing, globally recognized expert on digital health and mHealth. And she triggered me to think about this idea of mHealth and public health interventions. And I specifically looked at, of course, equity in access to this technology, in particularly a Kenyan population. And I began to think to myself, like, could this digital health mHealth thing be the Occam's razor, like the one cross-cutting solution that helps us target a lot of public health inequity and a lot of public health issues? And it's something important for some of you to think about today. And the reason I put it in my slides today is because you will be thinking about not just the tool, right? Not the AI, not the actual program you're developing, but you're going to think about the packaging. You're going to think about how you're delivering it and how the people that you are targeting are going to be receiving it. And that comes a lot of times in mobile phones, right? So a lot of your AI tools may be coming through mobile health technology. And so I wanted to give a couple slides on that. So in this work particularly, we were looking at various conventional and unconventional means by which people would receive information about this access to care intervention. That included things like community gatherings and radios and telephones and so on and so forth, and also included the use of SMS or text message reminders. And Dr. Riley kind of let me know if I break up at any point and I'll switch out. I think we're doing okay. And so SMS, for those of you that don't know, are short message services or text messages. And so I was able actually to look and see how effective the mHealth technology was in this aspect of the as a component of the intervention. And to our great delight, SMS was actually really effective in this slum population, really poor, really vulnerable population in Kenya. And my work is not the only work that's shown this, but it's actually ubiquitous across a lot of low and middle income populations. So encouraging, right? Mobile health technology might be able to work. But even more encouraging was that for other vulnerable populations, like older age groups, women, people of lower earnings, and people that work fewer hours, so whom are economically disadvantaged, they also were more likely to access SMS than a lot of the other conventional means of information and health education, which is also encouraging. And lastly, this population that I care a lot about, which is women who tend to be extremely vulnerable, disadvantaged, and lack a lot of agency in many of the low and middle income country settings that we're working in. SMS was actually twice as effective than their counterparts, males, even though in a lot of contexts, like where I work in Kenya and Africa, there might just be one mobile phone in the whole household. And yet women were still reporting accessing this twice as likely in this important public health intervention. So mHealth, digital health, very broadly. Occam's razor, maybe. I think so, and it's something that I've spent a lot of time working in since then. Okay, so that's sort of our little bit of background, who I am, why mHealth, why digital health as an opportunity, as a tool for leveraging equitable outcomes. Okay, why should you care about AI? And some of you might be hopefully not rolling your eyes, but you're still here, so that means that like you're engaged and you're interested, and the talks this morning were really revved up. Well, it's already here, right? AI is here. It's already playing a role in diagnosis and clinical care. This is from the WHO Director General. And the future of healthcare is digital, like if you've been under a rock for the last 10 years. And we have to do something to hopefully promote universal access. We don't want this to be another forum, another driver for inequity, another opportunity to have certain populations that are lagging behind each other. And so even for me and many of you in the room who are ER doctors or EM physicians, maybe you're in public health, maybe you played with a little bit of MS-DOS as a kid in your dad's computer office, right? Or somewhere along that spectrum, you are able to bring something mindful to your work and to the table on AI and contribute with your clinical and other expertise to be able to ensure that there's equitable access for these populations that we really care about. So with that, I'm going to give you 3 use cases on how I've applied it in various global health settings and thinking about landing that for you guys. So first of all, AI for extraction of data from large data sets. I'm sure several other people are going to talk about this based on the list of speakers, but also thinking about yourselves, no matter where you're coming into this angle of AI, from thinking about yourselves as expert and contributing to user-centered design, guiding implementation, and how AI is applied to our patients, and then also for optimizing bedside care. All right, so my first example is this idea of extraction of data from large data sets, which you've probably heard of, about these hugely powered machines that have the ability to look through large amounts of data and do it efficiently in a much quicker form than a human would. And so specifically for this study or this project, we used natural language processing for identification of gender differences in heart attack patients in a large data set in Pakistan. Amazing team of emergency physicians, transdisciplinary, trans country, and our work was just accepted actually a couple weeks ago in JAMR, finally. It's out in preprint if you want to read the current version with the Lancet. And so just to define NLP for all of us today, it is a field or method that uses algorithms which allow machines to identify keywords and phrases in natural language corpora or natural bodies of language, right? Human language, like unstructured written text. And a common example, of course, in the medical space are clinical notes, right? We have to write charts on all of our patients. And if you're working somewhere that doesn't, please let me know. No, I'm just kidding. But we have to write these large bodies of text, and NLP can come along and actually search through these and make some sense of it and like spit out things that we tell it to do, right? And so our study aims for that particular project were to develop a novel NLP model that would extract clinical data on heart attack patients from this data set. And then we also wanted secondarily to identify sex-specific differences, both in how the patients were presenting and also on clinical management, what happened to the patients after they were diagnosed. So what did we find? Well, large data set, like I said, 5,000 charts, little much for a human to be able to glean. And at the very bottom, you can see that the NLP tool was actually able to extract around 3,400 discharge summaries that had an AMI or heart attack symptom that was in the chart. There were some that did not. Over on the left panel, you can see perhaps the patient had been transferred, or maybe the symptoms just weren't documented because it's a discharge summary. Sometimes discharge summaries don't have symptoms in them or clinical complaints in them, or maybe the patient had passed away. And then on the right side of the screen, you can see that medication outputs and medication documents, medications were documented as well, 4,300 times or in 4,300 charts, and sometimes not in cases maybe where patients were transferred or the chart was incomplete and so on. So really effective at actually gleaning a lot of data from a huge data set that might otherwise not be possible in certain settings like this that don't have the human resource or capacity to do so. So this was really interesting because our NLP model, one, was novel in this setting, using it in a clinical corpora of text, but also in the outcomes that we presented as a result. And we were able, because of this large data set, to show systematic differences, unfortunately, but fortunate for enlightening our care, across women and men. And so men were presenting more conventionally with things like chest pain and sweatiness that we know about from the West. But women presented more atypically with things like shortness of breath and belly pain, nausea, vomiting, and weakness. And then very interesting to me, because every researcher has that one thing that was like this like gold nugget from the research, the model actually found a new word that we had not thought about, that we did not program it to do, called gabrahat, which is actually this culturally specific and context sensitive term that could actually incline providers to think about in future as they're caring for patients. And also interestingly, though it was not statistically significant or did not rise to show that it might not be just due to chance, it was actually slightly predominant in women. So again, interesting to think that women might be presenting with these very typical and like sometimes culturally sensitive vague terms. Also in the work with the medication piece, we did find systemic differences. So women were less likely to be prescribed all 4 of the first-line medications. And so we're really glad to have this work to be able to, again, enlighten this particular context, showing that NLP does hold water, can be used in these contexts, including in written formats and turning it to a digitized format and applying an NLP model. Diverse teams were key, and we felt very strongly about that. And without the diverse team that we had, we felt that our success would actually probably have been reduced. And unfortunately, clinical symptoms and sex differences did actually vary. The next thing I wanted to take you guys to, in thinking about extraction of large data sets, many of you can apply to all your different settings, I'm sure, is also thinking about your role as an expert and user-centered design. And so specifically, thinking about AI already being here, right? So whether we want it to or not. And so in this case, this is actually, and of course, sorry, I wanted to highlight, we are emergency physicians. For those of you that don't know, we are thinking about these problems among multiple clinicians pre, intra, and post-hospital phase. And so this is something that we've been doing a lot naturally by nature of our training, right? Thinking about how you apply big solutions across the multiple problems across healthcare systems. And so we are a good fit for this kind of thing. And so in this case, I was using in a community-based or public health setting, and we actually got a grant from Gates last year on catalyzing equitable AI, and we looked at its use in large language models targeting non-communicable disease risk factors in education in Kenyan youth. Once again, very diverse team, clinicians, engineers, Ministry of Health folks, and so on. And specifically, the two aims that are important for this presentation are that we were looking actually at knowledge, attitudes, practices, and feasibility of implementing these LLMs, meaning Chat, GPT, and Bard, for healthy education in this population. And we were also comparing their efficacy and seeing what our output would be. We had a mixed study design. We were looking at young people, 18 to 35, and we were looking really at community-based settings, like I said, going to schools, markets, and so on. And so we developed a very simple app using both tools out of box. The young people were randomly assigned to Bard and ChatGPT 3.5 at the time. And they had some nudges in there to tell them to go look up certain things or search for certain types of things within non-communicable disease education, like tobacco or alcohol. And interestingly, really encouragingly, it was highly feasible, right? And so, like, regardless of population, and there's this number called a p-value over on the right side of the screen, which, as long as it's greater than 0.05, means there was no difference. There were actually no differences, like whether it was by age, by sex, by location, that's rural versus urban, and so on and so forth. People like thought, wow, this thing is feasible, both reflecting the app and the use of LLMs. And we found some of this as well in our qualitative interviews. They were open to using it in the future systematically for Kenya. But when we looked at acceptability, we did have some problems, right? So we actually did find quite a bit of differences there. So for younger people, they were actually more likely to find it acceptable, right, for themselves to use, kind of along with the same domains that we'd think about. Same thing, unfortunately, for women, they found it less acceptable as well. And then the same thing for rural versus urban, and then by education, right? So those with lower education and those in rural settings found it less acceptable. And they still wanted that human touch in terms of some of their work or some of their health education. And so we were excited to find that it is feasible, probably with some user-centered design in terms of targeting different populations and youth populations. And so some of our next steps and some of the things that even you as an EM or public health or smart clinician could be thinking about is how do you then now tweak it to make sure that it is equitable across those populations? I'm going to wrap up just quickly on my last example, which is this idea of optimizing bedside care through clinical diagnostics. And specifically, hopefully many of you have already heard of the use of AI across different digital tools. We have a third project that's coming up looking at the use of an AI model or package in EKG reading. It's actually been used in certain settings like in Asia and South America, but really not been trialed in Africa. And so I'm working with some neat colleagues over at Stanford in computer engineering and working on that with an NIH grant forthcoming, hopefully, to be able to apply that in our clinical context. Because again, you have these clinical settings where people may not always be able to read EKGs, but if you have the use of AI or an AI tool be able to help them to read the EKGs, that can actually improve clinical care and improve equity and outcomes. And just to say that, oh, by the way, there are AI tools and packages for many devices, whether ultrasound, it's already being used in many of our radiology rooms in the US for CAT scan reading and X-ray. So it's here, it can be used. Ask about it if you're interested in getting involved. I'm sure many of your different radiology departments would be keen to have you contribute. This slide is just to say, and because of time, I'm going to skip through this, is just to say that not all that glitters is gold. Of course, there are so many limitations on AI, the packaging, like I talked about, making sure that the data that we're testing models on are not biased and inclusive, including in global health, that is cost effective and safe. But just to say, let's not throw the baby out with the bathwater, right? So AI is here. We can still contribute to it, make sure that it's being applied in the most effective and equitable way. And with that, I'd like to say thank you. Thankful for all of my support, and please do get in touch, email, across social media. And with that, I will stop sharing. Thank you.
Dr. Ngaruiya, thank you so much for that. That's fascinating. I have so many questions, but I will hold off along with the audience until the end. Next, we have Dr. Brian Rice, who will be sharing his work. So Dr. Brian Rice is a clinical associate professor in the Department of Emergency Medicine here at Stanford. He is the research director for Global Emergency Care, a U.S. and Ugandan-based NGO focused on providing task sharing and training in emergency medicine for non-physician clinicians. His current research focus efforts on the medevac utilization by non-physicians in rural Alaska Native communities and is supported by the National Institute of Health.
Well, hello, everyone. Let me see what I can do about sharing the correct desktop here. All right. And, all right, hopefully that's working. Hey, everyone. Thank you, Christine, for that awesome presentation. I actually had the pleasure of working with Christine when we were both fellows at London School of Hygiene and Yale, and it's amazing seeing how her career has taken off. My own work, I have a insatiable appetite for talking about myself, so I'm going to try to keep this part really, really short. I am a practicing emergency medicine physician, a clinician researcher, and my background in global health research, looking especially at use of unstructured free text in Ugandan non-physician emergency care delivery, has transformed into some work domestically, which has been my focus over the last bunch of years, looking at the sort of intersection of AI and rural medicine and AI and health disparities. My disclosure, my work is currently funded by NIH, the National Institute of Minority Health and Health Disparities. And as of a couple of weeks ago, the AIM Ahead program, which is an artificial intelligence machine learning consortium to advance health equity and researcher diversity. And we'll talk about sort of some of the directions of how this has come as we go through. And rather than spending a ton of time talking about some of the larger issues at play here, I thought it would be interesting to kind of dive into some of the nitty gritty of this work that we're doing, and sort of this through line that we have of this very, very challenging clinical scenario, a huge demand by providers and patients for assistance with it, the applicability of AI to this, and our implementation pathways for this. We're talking about a very unique healthcare system in rural Alaska, which I don't know the full makeup of everyone who's at the presentation here today, but it's a pretty unique system that's pretty poorly understood and described in the lower 48 states. So I want to take a couple of minutes to talk really about what this, what the clinical situation looks like and what the role for AI is in it. So the Alaska Tribal Health System serves the Alaska Native population within Alaska. And so in big cities like Anchorage, they have big hospital centers like the Alaska Native Medical Center, and it's pretty similar to how healthcare is in the lower 48. If you're, oh, all right. Oi, sorry. Lag time there. If you get sick, you can stay home. You can go to an urgent care. You can see a doctor. You could go to see a mid-level. There's an emergency room you could drive to. If you're sicker, you could take an ambulance, or if there was some massive medical or traumatic injury that happened at a larger distance away, that you could take a helicopter to. This is pretty similar to any big city ER situation in the lower 48. However, Alaska, over 80% of it has no road system. It's entirely disconnected, which is either those lines, those are the only roads that exist. Yet that is not the only place where people live. The initiation of our study happened in I'm sorry, to talk, before I forget, this work that I'm going to be talking about is a huge, sprawling mixed methods study that has a large number of co-investigators and community partners. There are 3 regional tribal health organizations that are involved, 1 statewide tribal health organization in academic partnership with Stanford. And I'll be trying to talk a little bit about how all that works through, but we're going to kind of drill down into some of the details about sort of this project and where we see it, rather than spending too much time on sort of the consortium architecture. So the first place that we looked at this is in the Yukon-Kuskokwim Health Corporation service area, which is this region in southwest Alaska. So to give some sense of scope, what we have here, the yellow area in the lower right shows this in the scale as compared to the rest of the United States. So this region is about 75,000 square miles. That's roughly the size of Oregon. There are 23,000 people, about 17,000 of them that live distributed in these 58 villages. There are these tiny rural communities dotted where there are entirely disconnected except by airplane. There are no roads. They all refer to a single hospital, which is in Bethel, which is sort of right in the center of the map. Geographically, you go from sort of outside of Anchorage in the Alaska range to this incredible appearing frozen river delta, and you end up out here. This is Tuksuk Bay, which is one of these locations, and that would be the structure that is the village clinic. So out here, this is as dramatic as I could do it. I feel like there should be some like da-da-dum John Williams music playing. No doctors, no nurses, no roads, right? So if you get sick out here, how can you possibly get care, or even how can you possibly receive routine care? And the Alaska Tribal Health System has come up with this really, really innovative spoke and hub system that involves an analog to basically like a village health worker. They're called the Community Health Aid and practitioner program. So community health aid practitioners are villagers who've received, they're non-medical, they're not physicians, they're not nurses. There are no physicians, there are no nurses in any of these regions. So these are villagers who've received a limited short course training, and they staff a remote village clinic. They staff this village clinic 24 hours a day, 365 days a year, in this very small, tight-knit community that is just their friends and family. And any of us who've ever tried to provide care for people that we know are in a small community, and those of us that were clinically, this is such an astonishingly challenging job, just that description out there. So there is a very algorithmic, that's called the ECHAM, the Health Aid Manual, which is a very algorithmically driven guide to providing routine checkups, well visits, med adjustments, and vaccinations, things like that. There's very limited diagnostic capacity at these village health clinics that are located in each of these remote villages. You have a couple of point of care tests. Notably, there's not things like troponins, but you could get like an H&H. You can provide IV fluids, assuming that the health aid is of an appropriate level where they're allowed to place an IV. You can get vital signs, you can get a history, a physical, a very, very limited pharmacopoeia, and basically no diagnostic capacity. And within this ECHAM, because it was built for sort of this primary care routine health thing, there is not structured emergency care guidance. Then we'll talk a little bit about like what actually happens when an emergency shows up. So if you're out here, you now have this new option of seeing a health aide, but all these other options, they don't exist. So if you're sick enough to go see the health aide and you need to get a physician level of care, the only way to access them is via a medevac. And these are actually fixed wing plane medevacs. We can talk about airframes and plane nerd stuff if anyone wants to do a breakout session on this afterwards and look at some pictures. But that the distances are too vast for rotor craft or helicopters. So that is an incredibly asymmetrical outcome. Basically, you stay in the village to get a, with Tylenol, recheck in a couple of days, or you need to get in a medevac. And this entire decision is being made by non-physicians with low information access in a remote setting. So I know this sounds pretty punishingly challenging. It is. I'm going to drill down into the details, going to go pretty quickly through this. But I don't know how much of the makeup of the crowd is clinically based and how much maybe more on the computer science part of it. And so we'll talk about this sort of like the clinical structure of what a emergency presentation really is. And my apologies if any of the residents who I worked with last night are here because they hear the same crap on every shift. But basically what an emergency is a combination of the patient, some objective data, the nature of an emergency, right? Like who this patient is, where they come from, how they talk about what they come from. Much of my prior work had been in looking at chief complaints in Uganda, which is, I found the Pakistan study that Christine had done very interesting, like how people talk about what they talk about in their own words, what that can give us, what their experience is with going to see their health seeking behaviors, their cultural fluency, their experiences with healthcare, all that goes into sort of who the patient is. There's some objective data about what's going on with them, vital signs, physical exam, limited testing in this scenario, and then the nature of an emergency, sort of the narrative of what happened, right? And so every emergency, whether in rural Alaska, urban Alaska, in Palo Alto, California, central London, it's all the same thing, right? And so the overlays of this are these environmental factors, right? So who is the provider? Like, how are they taking, two different providers seeing the same patient are going to take different histories. What's their experience? What's their training? What does in this case, the health aide bring to this experience? On top of that, there are these really, really profound larger sort of like systems and environmental factors. What are the supplies that they have? What is the training at the facility? This is the big thing out there is the weather. Right, that it's people say things like people die because of the weather, and that this is just an accepted fact of living off the road system in these rural areas, and that weather front comes in, you need to see a doctor, you can't fly, the patient dies in the clinic, right? And so current weather, impending weather, this is a big driver of this. And also needless to say that this is so Alaska is the most dangerous flying in the United States by a large margin, and that there's a calculable and non-zero chance of death just getting into the plane. So this all just goes on the patient side of things. And then the additional layer of complexity to this is the decision-making gets made with a physician on the other end of a phone or a video call. There is extensive video telehealth capacity that ATHS has installed in these clinics. It is not routinely used for emergency care. Which is a huge opportunity for implementation that we'll hopefully get to at some point in the next 5 minutes and 20 seconds. So on the other end of the phone is this other huge variable, which is the physician. And so there is a very bimodal distribution of healthcare providers out on the physician side in rural Alaska. There are a bunch of people who have decades out in this system, a huge amount of domain knowledge. There's also a large group of new grads and locums because long-term staffing in rural Alaska is a huge challenge. And so many of these are new grads who've never been in this situation before, trying to navigate this nearly impossible question over the phone, week 2 out of residency. Additionally, emergency medical services, has the aircraft timed out? Have they already flown too many hours that day? Are they available? Are they on another call when there's only one flight crew that has to address this entire area the size of Oregon? Where do you go when? What do you do with concurrent emergencies? And then what are the capacities at the referral hospital? That's a 2-tier spoken hub system. There's the main hub in Anchorage, ANMC. And then these rural hubs that are dotted throughout sort of each of the larger tribal health organizations, which have physicians staffing, but no surgical capacity. They can deliver babies and admit, but there's no ICU, there's no surgical services, there's no subspecialties. Most of this is run by rural family practice grads from the WAMI region. So when you're out there, the emergency happens, these 3 choices exist. You can stay in the village for a recheck in the Tylenol. You can get on a next commercial flight, which is this sort of third type of heat that happens in the middle of this that is outside the scope of our limited time here together to possibly get onto. But you can say, oh, this person kind of needs to see someone in the next day or 2, and they could go on a commercial flight. Or if someone is really sick, has a potential to be sick, or you don't know what's going on, do you get them on a medevac? So that was about 5 minutes of how confusing things can be. This would be what a structural model of that is, with sort of error terms. Depending on everyone's methodological bent, this is either a welcome sight or a horror show. This is just sort of a way of flow charting the stuff that we were talking about. So we kind of talked about like what is unique about this health system, and I hope this is one of those windmills to tilt out of this astonishingly complex problem that is such a huge clinical problem. So this is to the clinicians that work out there, this is absolutely the hardest thing in their jobs. It's not taught in any curriculum in family medicine, emergency medicine. There are no systems level directives on what is supposed to be done with this, from the flight crews to the physicians to the patients. And, when we take this to the boards and the tribal elders and talk about this, everyone is involved. This is the ground truth for everyone living in these communities, is that at some point you will get sick, and at some point someone will need to decide, do you need to fly, and when do you need to fly, and who flies first? And this is just this overwhelming clinical need. And the truth is, nobody has any data about this to date. There's at least 3 different disconnected health systems, EHRs, that this patient record is tracked through. There's no feedback. This decision making is made ad hoc. And there's no clinical decision support for this to date. It ends up producing, I'm going to be starting to go really fast here, you guys. It produces some incredible outcome disparities where rural Alaska has very, very, very high mortality rates for emergency care sensitive conditions. Medical and surgical, it's about an 80-20 split for medical to surgical. The prelim data that we have that these projects started about 2016. There's been a lot of negotiating these different health systems and entering into data sharing agreements with sovereign tribal nations, and that this has been a long, slow, like the legal process and the data access part of it has been slow. But we do have our first prelim data that has been coming out pretty recently. Basically, full stop, there's a huge number of these that happen. About 3% of people per year in these regions get a medevac. And about half of them have had a medevac within the last 5 years. What we see as far as the outcomes for it is that about 30% get transferred to the higher care facility in Anchorage, about 30% get discharged, and about 30% will get admitted to the regional hospital. The 30% discharge rate would be a lot with that is a higher discharge rate than you see with ambulance runs in the lower 48. Medevac runs in the lower 48, it's about a 1 to 2% discharge rate. And so this is a very different systems, and it's very hard to say what the right level is because we haven't been able to tie it into patient outcomes. And so that's what the NIH funding is for this project. I've got about 1 minute to go here, and so I'm going to just kind of rip through what we're doing. So the complexity of this has led us into this. We're trying to build a classifier model, and that there's a whole arm of this, which an entirely different presentation could focus on, because there's a qualitative arm where we're actually interviewing the providers to figure out what variables that they weigh, how they weigh them, what they take into account as far as clinical things about the patient, as well as non-clinical things about weather, environment, their training, the other things that sort of go into this. And that we're going to try to build classifier models that are able to look at medevac appropriateness as a binary yes, no, appropriate, inappropriate, and as also a 3-tier one that would look at the transportation choices. And basically the idea is, can we identify high-risk medevacs where we have an archetype of patient that when they get medevacs that we see improved outcomes as compared to when they don't, or when those are delayed, and that we can then identify features that we could feed back into the training program that would help the providers ask the correct questions and prioritize the right medevacs. The second thing that we've seen, that's this second whole direction of inquiry, which is into predictive modeling. Once we saw this really high rate of recurrent medevacs, and we started looking at the archetypes of these patients, it's seizure disorder, it's heart failure, it's patients who have potentially avoidable healthcare utilization, but in this case, it's not like an urgent care visit for IV fluids because you're dehydrated. It is having to get in a medevac. And is there going to be a way where we can identify patients who are at high risk for medevac utilization and then have a intervention via telehealth or other sort of clinical contact that could help prevent these things? I have run all the way out of my time. I apologize. I'm on last slide here. Please reach out. Well, hopefully there'll be questions afterwards, and I appreciate your time. Sorry, I ran over.
Brian, that's so fascinating. You always hear about the vastness of Alaska, but you don't kind of realize it until you see some of these scales and graphs. So thank you so much for sharing that. Okay, all right, moving on to our last speaker. So Dr. Stephen Gradwohl is a pediatric emergency medicine physician at Vanderbilt University. He is board certified in clinical informatics. He advocates for the thoughtful integration of technology into healthcare to improve patient outcomes and streamline medical processes. He is the co-founder of Clintuition, which leads the development of generative AI applications for medical education and simulation. All right, take it away, Dr. Gradwohl.
Excellent. Can everyone see my screen? Okay. Okay, hope so.
Yes.
All right, guys, very nice to meet you. I'm so glad to be here today, and it's just very exciting to be a part of this conference and just hearing what everyone's doing with AI. I'm sure, like everybody, just seeing what this stuff has been able to do in the last few years has been pretty incredible, and it's really kind of forced me to rethink what is possible. I think as I've played around with some of these large language models and just seeing the conversational nature, it's really sparked an idea that has led me to innovate in this space and really rethink what we can do in the area of medical education. And that resulted in me starting a company to develop software to build a new kind of patient simulation. Let's see. So let's start with a patient. So this is Emily Thompson. She's a 17-year-old white female. She's coming into the emergency department. She's coming in with shortness of breath and came on suddenly. And she's very concerned because her albuterol is not working like it normally does. Again, she has a history of asthma. She's also on oral contraceptive. She vapes regularly. She has a history of family history of factor V. A little bit about her: she's optimistic, assertive, extroverted. One of her goals: she's a lead in the school play, and she really can't miss it. Her values are responsibility and commitment. And her physical exam: she's breathing fast, her heart rate's fast, she's at 92% saturations on room air, but she has clear lungs. Her diagnostics: a D-dimer is elevated, chest x-ray has no acute findings, and her chest angiogram shows a large saddle emboli, pulmonary embolism. So, this kind of a patient can be used in all sorts of types of simulation-based learning. So we have case studies, and they're low cost, and they help us develop critical thinking and problem-solving skills, but they're static. They're not dynamic. You can't interact with them, and it's really more based on your reading. High fidelity simulations are really an amazing tool. They cost a bunch, and they are immersive and help us develop hands-on training, but they're very specific. They're for acute care and resuscitation skill sets. OSCE simulation is another way to do it. It's also pretty high cost. And it's where we use an actor or an actress to basically kind of create these interactions. And this is awesome because we can really develop our diagnostic process of deciding how we want to kind of ask the questions, what order we want them to. But again, they have high costs. And ultimately, on the other end of the table is a actor or actress that doesn't really have profound medical knowledge and has a limited ability to respond to the many types of questions that we might ask. And so I see a gap here. I see a gap where we really want to have a low cost scenario, but also allows kind of this dynamic, really rich interaction. And so this led me to ask the question, well, what if AI could bring my patient to life? We've seen all these really cool conversational examples. What if I could use this to kind of create a patient and have authentic conversations that adapts and responds in real time? And then when we're done with this interaction, can we take that interaction transcript and provide guidance and feedback with it by creating an AI tutor? And so this is what we've been focused on at Clintuition with this company. We created a custom patient creator, and this allows educators to customize their specific patient scenarios, kind of like a script that you would hand to an actor or actress, and create captivating learning experiences. We created an interactive AI simulation environment that takes that script and takes that template and brings it to life so you can actually interact with it in a conversational layer. And then when you're done with that, we've created real-time feedback. And the goal is to enhance our diagnostic, management, and communication skills, which we'll dive into in a little bit. And ultimately, what we're working towards is kind of analyzing this learner data and identifying the growth opportunities, monitoring that advancement, and enhancing the learning experience overall. So I want to jump in and demonstrate what we've been working on. So this is our patient creator. And on the right-hand side, you can see basically a GPT that I'm utilizing to demonstrate this example. And again, we can start from scratch where we can build a patient, piece of information by information, or we can even use existing content. So what I'm going to do is demonstrate taking the patient that I presented at the beginning of this talk and show how it can take all that information. It's consumed by the GPT and it formats it exactly how we need to for our patient template for this software platform. And then we can save it directly into our server, which it will then store and provide us back a link. And by clicking this link, I can jump directly onto our platform, and I can jump right into a simulation. And now I'm talking with Emily Thompson, the patient I demonstrated before, and I can go through a conversation with her. So it shows you that within less than a minute, I can take information I already have and turn it into an AI patient that's ready to talk with us. So I want to demonstrate the patient simulator. You can see here, I'm basically just having a conversation like I would with any other type of patient. I'm asking general questions and I'm getting dynamic answers. I asked, when did this start? She tells me it happened while she was at her school play, that she can't catch her breath. In the next question, she really emphasizes how she can't miss it. And you can see that I have control of the diagnostic process, that I can ask the questions in the way I want to ask them and get the information that I'm interested in to make my diagnostic decision making. So when I'm done talking with the patient, I can request physical exam findings. And here I can show that I can pick different ones from a drop-down menu, but because of the impressive nature of the large language models, I can pick any or type any type of exam finding I'm interested into that view. And then when I'm done, it kicks out the responses of each of those exam findings. So you can see them listed out here as well. I can move on and ask for diagnostic studies. I can enter in those things that I mentioned in the template. And we can see that the GPT will then generate those findings. Now, for an early learner, we might want to generate results that are very more basic, so like a D-dimer being elevated. But maybe for a more advanced learner, we can actually create a filter where it actually will then create the units and the normal ranges so that the provider has to interpret them. Ultimately, what I was really impressed with, just the ability for these large language models to be able to do, is kind of create this experience where I have to then explain what's going on to the patient and practice that closing of an encounter, where I summarize all of the events that happened, what I think is going on, what we should do next, and explain what the overall care plan is. And what's really interesting, what's really pushed me, is that the AI as a patient, will push back and ask more clarifying questions. For instance, down here in this example, the patient asks, can she still participate in her school play? And then how can I keep this happening in the future? And so it really kind of helps me refine that skill set, which is often missing from most types of medical simulation experiences. And finally, we built a tutor on top of this that allows us to ask questions to help us improve our overall process. So in this example, I asked what kind of questions I should ask. And this is again back at the beginning of the simulation. But you can see that it gives me a few different kinds of questions that I should explore and help guide me. So as an early learner, this could be a very profound tool to improve their overall diagnostic process. When we're all done, we can basically provide real-time feedback. And so right here, you can see it's basically generating a diagnostic skill assessment based off a rubric that we designed. And it's basically giving an assessment, a justification, and then gives recommendations. And we think this is going to have a profound impact on our learners, that they can get this kind of information and feedback in real time. On top of that, we are basically working to create custom assessments. So if an educator out there wants to create a very specific way of assessing their patients, they can do so and do it in real time. We're also exploring feedback like human-in-the-loop systems, so that way an educator can have a little bit more fine-grained control over their feedback and assessments. So overall, we're trying to create a more intuitive way to practice medicine. First and foremost, we want to create a high-quality learning experience. We're creating these immersive, realistic simulations that mimic these real-world scenarios. And we want to foster that deeper understanding and retention of information and skills. Again, we want to empower educators. We're not trying to replace the overall experience of medical schools and training programs. We really see this as kind of following alongside and allowing educators to have this very powerful tool to capture the experiences that they experience and share them with the world. Again, I think we can all think about patients that have profoundly impacted us over our careers. And what we hope is that you can encapsulate that information into our templates and that others can learn from those experiences as well. Again, by creating a cloud-based platform and using AI, we can create a scalable, accessible, and a very affordable solution that can be spread around the world. And overall, we're trying to provide this personalized learning where we can adapt the simulations in real time. We can push different types of simulations that will overall meet people where they're at with their individual skill levels and focus on overall continued growth. So where are we at right now in the opportunities we're presenting? We are welcoming collaboration. You know, we have this very sophisticated prototype and minimal viable product, but where we want to go next is expand our beta testers. You know, so far we've had lots of doctors using this platform and giving us incredibly valuable insight, and we want to continue to scale that across different specialties and different institutions. So right now, today, you can join our free beta program. You can try out our software, tell us what you think, and overall, your feedback will be used to help make this software better. Again, we want to collaborate for content creation and collaborate with our educators. Again, we see them as the most powerful ally here to help make our community better. And finally, we want to do this right. We want to do pilot studies. We want to really, in a very appropriate and rigorous way, evaluate the accuracy and reliability of our AI systems so that we can address any potential concerns. So again, I invite you guys to explore our AI patients today. You can check the QR code out on the left to check out our platform. If you want to see the patient that we built today, you can check out Emily Thompson on the QR code on the right. And then you can check us out on social media or reach out to me personally. And I'll pause there.
Thank you, Dr. Gradwohl. That was super interesting. I can already see how the three of you guys could collaborate and how this could be used in a lower user settings to train some of the people that were already mentioned. Okay, great. Well, we have 9 minutes left, so we'll why don't we start with a question each? So Dr. Gray, I'll start with you. I think we can do like 3 minutes per person. Okay, so Dr. Gray, one question I had for you was, you know, here in Silicon Valley and definitely across the US, there's people who are in many ways excited about AI, we know, like fastest growth, app, et cetera. But then there are obviously hesitations. What were some of the things that you saw, you know, kind of in the settings that you were in, that may be similar or different?
Wait, can you say it again?
Oh,
Similar.
sorry, that was the Dr. Ngaruiya.
Oh, I'm sorry. Great.
Oh, it's
Yeah,
okay.
thanks. And I think my video, but that's okay. Okay, great, perfect. I'm being asked to start it. Great, yeah. So interestingly, I found had results contrary to our hypothesis, which is that there would be a lot of trepidation around engaging with the AI tools. Just like I said, even with this last study with the Gates AI program, where we went in with this plan to fail, right? And I think I laud Gates for actually launching that call on catalyzing equitable AI, and others can look for it too. They renew, I think they're, as far as I know, they're still continuing to renew it every year. Where we thought like a lot of these kids from various vulnerable populations would actually not be amenable to using it. And we were stopping in the middle of the street and asking them to play with the AI for a bit, watching them for 15 minutes, sending them off with it for a few months and monitoring. And like you saw, number one, our recruitment was really high. So folks were all like, yeah, I want to use it. I want to try, I want to play with it. And then acceptability was also really, feasibility was also really high in terms of thinking about the long-term applicability across Kenya for different health implications. So I'm encouraged. And like I said, like I started out with a bit more foundational text around mHealth more broadly. mHealth, you know, like is expanding vastly across places, including Africa. Actually, I told our founders today that Kenya is actually referred to as the Saharan Savannah, I think is the term. So like mobile phone connectivity is increasing at a wild rate and people are interested. There are policies that are being set up by governments around AI use and ethical AI use and so on. So it's encouraging. And I would absolutely love to talk to Dr. Gradwohl about collaborating after today. Thanks for the question.
Keep your
Okay,
hands off
perfect.
mine. All right.
Yes, exactly. Building the greater StEMI community. Okay, perfect. And then Dr. Rice, this kind of applies to a couple of projects here, but I'll just direct the question to you, which is, you know, a lot of these projects or address underserved populations, and obviously many of you guys are supported by, you know, federal grants and other grants like the NIH and things like that. But do you see these independently becoming profitable or financial viable so that they continue to be sustainable and serve these underserved communities
Yeah. So
forward?
it's a really interesting question, right? And so a lot of these outside in development efforts in global spaces the sustainability of the funding, and is a huge issue. As a more sort of like micro answer about how things work within the ATHS, there's a lot of these. The NIH funding that's going into it is about local capacity building, and so basically it's trying to build these things as an inside out thing. So what we're trying to do for the sustainability for it, profitability would be a different thing, right? But the economic sustainability is that these are closed health systems, right? Where the money comes from the IHS to the individual beneficiaries who, as tribes, then form these health corporations, which then administer these health systems, which co-own and run these medevac systems. So finding more efficient, equitable, and effective care is actually reminds me some of, I did do my medical training in Canada. These like the incentives are towards these efficiencies. And so the idea is it's going to develop the technical capacity to help implement these tools internally. And that would be sort of like, it would be building part of this health system, which would be funded internally into perpetuity. So if we're able to find either training innovations or, everything from education training interventions to a really nice laminated piece of paper and a white dry erase marker that tells you what questions to ask based on this analysis, all the way to a like EHR implemented up and running clinical decision support tool. All of those things would ideally be coming sort of like from within it. And the issues of acceptability and feasibility are also huge obstacles and working in these areas with sort of very traditional research abuses, and like how these outside interventions are viewed, and how the community engagement and community first design of it is like, hearing the stuff that Christine is going through, like there's very similar work that's happening on this end that is part of this like sustainability, because if it's not desired and built by the THOs, it's not going to be sustainable. Like this will never be a commercial project or a Stanford product. There's hope that the findings that we have will be able to find ways to be applied to rural health resource utilization statewide, right? There is like this through line that is a longer, broader thing, but sort of like within it. I know that's a very meandering answer to a very specific question, but it's something that we've thought a lot about, and sort of within this space, it's that's how we foresee the sustainability.
Okay, perfect. Yeah, no, that's good to know, because these are such important projects, and one would hope that it'll become, the sentences will be aligned such that it'll just grow. Okay, and lastly, Dr. Gradwohl, for you, so people kind of, as we all know, AI is super exciting. It also has some of its limitations, like for example, hallucinations and things like that. In incorporating AI into medical education and simulation, what are some of the challenges that you came across kind of in this unique corner, of EM, if you will? Like, for example, the hallucination example, I can imagine in some ways trainees would be less able to kind of recognize things that, or taking, may be less able to question that and things like that.
Yes, it's a great question. So absolutely, that's kind of the nature of these things, right? They're probabilistic. So like the chance for hallucinations, just flat out incorrect or false information, it's there. It's not avoidable. But the cool thing is, like, I mean, this field is moving so fast. There are really neat frameworks. Again, I mean, if you are kind of just working within just a single chatbot by itself, you are incredibly prone to these types of problems. But once you kind of move into more of an agent structure, or like a graph type structure, you can actually build in systems that can do kind of auto checking or error checking, or they can compare to against like a knowledge base or knowledge graph. Now, this can come with latency issues, and so you have to kind of balance that depending upon the risk and the of the information and the error at hand. But these types of things are being built in. I think hallucinations will always be part of it. I think the goal is to try and minimize them and create scenarios to flag them so we can better understand them to try and then minimize them in the future. But it's a great question. It's definitely where I've spent a lot of my headspace as I've worked on this problem of, as we've gotten more examples, more people trying to use it, seeing that, hey, okay, this happens here, it kind of doesn't happen here. That is it is a fun area to be working in right now, and I'm sure others can relate if they've played with these types of chatbots and infrastructures.
Okay, perfect. Thank you. Well, with that, I think our time is up. Thank you so much to all of you guys, to all three of you for joining us and talking to us about your projects. I know I've enjoyed them. I'm sure the attendees will, and I will be sharing these with our trainees and anybody who's looking into kind of getting into some of the lesser thought niches. So thank you so much again for your time. Dr. Rai, especially I know it's kind of late for you. And we'll see you at our pitch event. All right, thank you.
Bye.
Thanks.